Now I'm going to go over a little nugget. It's here in the bundle branch block section. It's a non-specific intraventricular conduction abnormality, or notch in the QRS. This isn't really important clinically, but it comes up pretty frequently when I'm reading ECGs with students and residents. They'll say, "Hey doc, what's that notch there, that little squiggle in the QRS? What does that mean?" And the answer is it doesn't mean much. It's really a very minimal clinical significance, and you basically can't even use it to change what you do with the patient. And it's defined as a notch in the QRS when the QRS is of less duration than 0.12 seconds. That's what it is. Now we're going to look in the infarct section. A couple of advanced topics here. We've got up here, the first one, occult lateral infarct. So this has come up a few times in my career, and once as a fellow we made a diagnosis as a result of understanding this concept. And that is that lateral infarcts are sometimes not visible on a standard 12-lead ECG, and you need to put on some bonus leads to check out for ST elevation. This schematic shows about where the leads V7, 8, and 9 would be put on the patient's back. And if you see ST elevation there greater than or equal to 1 millimeter in one of these leads, then that suggests the presence of an occult lateral infarct. So if you have a patient who's having classic chest pain symptoms, it really seems like they're having a heart attack, and the ECG isn't showing anything, or maybe there's just a teeny little bit of ST elevation in leads V5 and V6 or something like that, you could put these leads on the patient, and then you might see something like this, which would suggest that they were having an acute MI and that it was just occult. Making that diagnosis could really change things for a patient. Okay, let's move on to this topic here, which is reading ST elevation MI in the presence of a pacemaker or pre-existing left bundle branch block. And with pacemakers, the most common form of pacemaker would be pacing the right ventricle, and that gives you a morphology very similar to a left bundle branch block. So it's a similar process in diagnosing Stemi with pacemaker or pre-existing LBBB. And these are called the modified Scarbosa criteria. You diagnose ST elevation MI if there are any of these three things. The first one over here is the easiest, and sometimes it's a little surprising to people that it's possible to diagnose a Stemi with left bundle or pacemaker, but diagnosing a lateral or inferior Stemi is actually pretty easy and basically the same as it would be otherwise. So you've got a P wave and then a left bundle QRS here in, say, the lateral leads, and then there's just straight plain old ST elevation. And then oftentimes the T wave goes in the same direction as the QRS. So this criterion is ST elevation greater than or equal to 1 millimeter in the same direction as the QRS. The second situation where you can read it is if you have ST depression greater than or equal to 1 millimeter in V1, 2, or 3. And this indicates a posterior ST elevation MI is happening. So you got your P wave, we're in V1 here, and then the QRS, and then the ST segment is depressed. So ST depression in V1 with left bundle is very unusual. It's atypical. What you're used to seeing with the left bundle would be something more like this, where there's ST elevation. Typically, it's more like this. So when the ST segment's actually depressed in V1, that's super unusual and implies ST elevation MI equivalent. Third scenario is over here, and it's probably the most complicated. And that's when there's ST elevation in millimeters divided by the depth of the QRS ratio greater than or equal to 0.25. And this is mostly seen in the V leads. So say we're in V2 here. The depth of the QRS, so that's here to here, in this instance, 9 millimeters. And then the height of the ST elevation, so ST segment's here, baseline is here, you've got 6 millimeters. So we take the 6 and divide it by the 9, and the ratio is 0.67, so that's way more than 0.25. And this would be an example of significant ST elevation in the precordial leads. Let's do some examples. So here we're looking at inferior Stemi and left bundle branch block. And if you look at V1, it looks pretty much like a left bundle. Same thing for down here, V6, classic left bundle. It's not so classic in lead 1, but close enough. So we got a left bundle, and then say we patient's having chest pain, we want to look for ST elevation. We know we can see inferior ST elevation MI with left bundle. So looking here, there is indeed ST elevation in the inferior leads, all of them, 2, 3, and AVF. And there's even some reciprocal ST depression here in AVL, and also in lead 1. So this is a pretty clear-cut example, and I've had a few of these over the years where the patients had inferior Stemi in the presence of left bundle branch block. Next one, anterior Stemi and left bundle branch block. So we've got a left bundle, just barely. It's about 3 little boxes wide, but indeed it's a left bundle, and patient's having classic symptoms. So we're going to apply the Scarbosa criteria, and here in lead V2, you've got ST elevation of about 2.5 millimeters. The depth of your QRS is about 6 millimeters. So 2.5 divided by 6 equals 0.4, and 0.4 is greater than 0.25. So that meets the Scarposa criteria. I personally find that criterion a little overly sensitive because a lot of patients with left bundle who aren't having any symptoms will meet this specific criterion for Stemi, and they clearly aren't having that. So that's something to keep in mind. But if you were ever to be tested or asked about this type of thing, the examiner would be referring to the modified Scarposa criteria. It's really the standard for diagnosing Stemi in the presence of pacemaker or left bundle.